These are two Medicare choices that look similar on paper, but one comes with a denial risk that could leave you fighting for coverage when you need it most. Medicare Advantage and Medicare Supplement. Insurance, also called Medigap, both promise to help with your healthcare costs after turning 65, but they work in completely different ways. Whether you're choosing Plan G, Plan N, or any Medigap option during Medicare open enrollment, buried in that difference is a critical risk that most people never consider until it's too late. Let me start with the numbers that insurance companies don't advertise. In 2024, Medicare Advantage insurers processed nearly 53 million prior authorization requests. That's 1.7 requests for every single person enrolled. Compare that to traditional Medicare with Medigap, which processed just over 625,000 prior authorization requests for the entire year. We're talking about 85 times fewer requests per person. But here's where it gets really interesting. Of those 53 million Medicare Advantage requests, 4.1 million were flat-out denied. That's a 7.7% denial rate just for prior authorizations. This doesn't even include the regular claims denials that happen after you've already received care. Now you might think if something gets denied, you can just appeal it. You'd be right if you actually appeal. Here's the shocking part. Only about 10% of denials ever get appealed. Yet when people do appeal, they succeed more than 80% of the time. Think about that. 8 out of 10 denials are wrong, but 9 out of 10 people never challenge them. The key difference between these two options comes down to who makes the medical decisions. With Medigap, Medicare makes the coverage decision first. If Medicare approves it, your Medigap policy must cover its portion. No questions asked, no prior authorizations required, no medical director at an insurance company second-guessing your doctor. This applies whether you have Part D prescription drug coverage as a standalone plan or integrated coverage. Medicare Advantage works the opposite way. It's a private insurance company that is contracted with Medicare to provide your benefits, including Part D prescription drugs. But they are operating under what is called a capitated payment system. Essentially, they receive a fixed amount of money per person each year, regardless of how much healthcare you actually use. This creates a built-in financial incentive to limit care. Chris Comfort, Chief Operating Officer of Calvary Hospital in the Bronx, puts this in stark terms. He says, "We take patients who are going to die of their diseases within a 3-month period of time, and we force them into a denial and appeals process that lasts up to 2.5 years. So what happens is the appeal outlasts the beneficiary." The denial patterns reveal something even more troubling. The April 2022 HHS Office of Inspector General report found that 13% of Medicare Advantage prior authorization denials actually met Medicare coverage rules. In plain English, these were services that would have been approved under traditional Medicare, but Medicare Advantage insurers denied them anyway. The numbers get worse when you look at payment denials, cases where care was provided but the insurer refused to pay afterward. The same OIG report found that 18% of these denials met Medicare coverage rules. These aren't borderline cases or experimental treatments. These are legitimate Medicare-covered services being systematically denied. Recent data from Health Affairs Journal shows that initial claim denial rates in Medicare Advantage have climbed to 17% as a share of all claim submissions. But here's the kicker. 57% of those denials were ultimately overturned on appeal. That means roughly 1 in 10 Medicare Advantage claims that should have been paid initially gets denied and has to go through the appeals process to get approved. The variation between insurers is staggering. United Health Group, the largest Medicare Advantage insurer with nearly 10 million enrollees, processes relatively fewer prior authorization requests, about 1.0 per enrollee. But they deny 12.8% of them. Humana, the second largest, processes 2.2 requests per enrollee, but only denies 5.8%. Centene manages to be worst of both worlds, 2.9 requests per enrollee and a 12.3% denial rate. There's also a disturbing racial disparity in these denials. White Medicare Advantage beneficiaries face denial rates of 7.3%, while Black beneficiaries see 10.2% denial rates and Hispanic beneficiaries face 12.2% denial rates. The very populations that often have the greatest healthcare needs are being denied coverage at higher rates. The technology making these denials possible has evolved dramatically. Insurance companies are now using artificial intelligence algorithms to predict and terminate coverage. United Health's subsidiary Navi Health developed something called NH Predict that uses AI to determine how long patients should stay in nursing homes or rehabilitation facilities. David Lipschutz from the Center for Medicare Advocacy explains the problem. He says, "While the firms say the algorithm is suggestive, it ends up being a hard and fast rule that the plan or the care management firms really try to follow." One example showed an elderly stroke patient who was allowed only 20 days of rehabilitative care, even though severely impaired stroke patients typically need almost double that time. These AI-driven denials have triggered multiple class action lawsuits. In February 2025, a federal judge ruled that a major lawsuit against United Health over AI-assisted denials could move forward. The plaintiffs claim that more than 90% of the AI-generated denials were overturned on appeal, supporting their argument that the technology has an unacceptably high error rate. Congress has taken notice too. A Senate investigation found that the nation's three largest Medicare Advantage insurers, United Health, Humana, and CVS Health, increasingly refused to pay for rehabilitative care in the years after adopting these sophisticated denial technologies. They specifically targeted denials for older adults requesting care in nursing homes, inpatient rehabilitation hospitals, and long-term care facilities. CMS has been scrambling to address these issues. They have issued new rules requiring Medicare Advantage plans to adhere to traditional Medicare coverage policies when making medical necessity determinations. They have also proposed guardrails for AI use, stating that artificial intelligence cannot be the sole basis for coverage denials. But here's something most people don't realize about the choice between Medicare Advantage and Medigap. It's essentially a one-way street. If you start with Medigap at 65 and decide later that you want to switch to Medicare Advantage for lower premiums, you can do that anytime during Medicare open enrollment. But if you start with Medicare Advantage and later want the comprehensive coverage and freedom of Medigap, you could be out of luck. Federal law requires Medigap insurers to accept all 65-year-olds when they're new to Medicare. But once that 6-month window closes, insurance companies can reject applicants for health reasons in most states. Only Connecticut, Massachusetts, New York, and Maine provide continuous access to Medigap policies regardless of health status. This creates what researchers call the trap for Medicare Advantage enrollees. If you develop serious health conditions while on Medicare Advantage and want to switch to traditional Medicare with Medigap for better coverage, you may find yourself unable to purchase a Medigap policy. You're essentially locked into a system that has demonstrated a pattern of denying legitimate claims. The premium difference can be substantial. In New York, where medical underwriting isn't allowed, the lowest-priced Medigap Plan G costs about $320 per month. In Arizona or California, where underwriting is permitted, healthy 65-year-olds can get the same coverage for about $110 per month. As one industry expert notes, quote, "Freedom from medical underwriting is not free." Quote, more than half of Medicare beneficiaries, 34.1 million people, are now enrolled in Medicare Advantage plans as of 2025. That's up from just 19% in 2007 to 54% in 2025. Many are attracted by the low premiums and extra benefits like dental and vision coverage, but most don't understand the denial risks they're accepting. The appeals process exists, but it's designed to discourage use. Even when appeals succeed 80% of the time, the fact that so few people use it suggests that the system is working exactly as intended, deterring people from fighting for care they're entitled to receive. This isn't about being anti-Medicare Advantage or pro-Medigap. It's about understanding what you're really choosing. Medicare Advantage can work well for healthy seniors who don't mind network restrictions and prior authorization requirements. But if you want the certainty that comes with Medicare's coverage decisions and the freedom to see any doctor who accepts Medicare, Medigap provides that, if you can get it and afford it. The denial risk isn't theoretical. It's happening to millions of seniors right now, backed by data from government investigations, academic research, and court filings. When you're choosing your Medicare coverage, you're not just picking an insurance plan. You're deciding who gets to make medical decisions about your care when you need it most.